thank you for the opportunity to speak. I'm going to start by acknowledging MND Research Australia that have funded this particular research project. I also want to acknowledge my co-authors and the NIV in MND Uptake Stakeholder Advisory Group that has supported this research for 2 years. So I'm talking about non-invasive ventilation, which is a machine that supports respiratory function or declining respiratory function by providing pressurised air to the lungs via a mask. It provides 2 levels of pressure, IPAP and EPAP. EPAP is the expiratory pressure, which is at a lower level, just enough to splint open your upper airway to stop it from collapsing during sleep. And then the IPAP, which is your inspiratory pressure, which is a higher level to actually support breathing. So it's known by many names, including bilevel therapy, BiPAP and VPAP. It's not CPAP. So CPAP just provides 1 level of pressure and it's used to treat sleep apnea only. There's an abundance of evidence now to show that NIV improves sleep, symptoms of breathlessness, fatigue and quality of life, and also at least 10 studies now to show that it improves survival. But we know, despite this evidence, hence my comment earlier, that the uptake of NIV in Australia is still low. This is old data now, but there was a study published that found that of Australians who lived with MND from 2005 to 2015, just 19% of them ever tried NIV during the course of their disease, sorry. This was a study that I presented at this meeting last year, which was the first study in my fellowship to try and understand and address the problems related to NIV uptake in Australia. And it was a national survey where we had 224 respondents, so 10% of the MND population in Australia. And I think the most important finding that we had from this survey was that from our multivariate analysis of these data, we found that access to NIV is inequitable across the country. So it is significantly related to where people live. If you live in Victoria, then you're twice as likely to use NIV than everywhere else in the country. And same with remoteness. So despite adjusting for the state, if you lived in a metropolitan area, you were 4 times more likely to take up NIV than if you lived in a rural area. And same with gender. So men were twice as likely to use and take up NIV than women. Those attending, we've heard a lot about multidisciplinary clinics, but if you attended a multidisciplinary clinic, you were twice as likely to have spoken to someone about NIV. And same with age. If you're under the age of 65, you're twice as likely to report speaking to someone about NIV. So this proved what we already kind of suspected, but it was nice to have some hard evidence about the fact that there is inequitable access to NIV. But what it didn't do was tell us why. And so the next 2 studies in my fellowship were qualitative studies to really try, to complement this survey study to understand at a bit of a deeper level what are the key influences on NIV uptake. And so we interviewed people both living with MND and their carers, and in a second study that I'm not reporting the results of today, we also interviewed clinicians. So as I said, we did semi-structured interviews with people with MND and their carers, and we tried to recruit a diverse range so that we got lots of different voices. We ended up recruiting 11 people with MND. So of those, we had 7 who lived with MND, of which 5 were male, and we had 4 carers, all of whom were female. We did the interviews over video conference, but we did have one participant who answered the questions over a number of weeks via email using eye gaze technology. And we had no one from rural areas, unfortunately, or from the territories. The interview guide and the interview analysis was framed by the COM-B model of behaviour. So this is a model that theorises that our behaviours, so what we do, such as accept a referral for NIV and turn up for an appointment, is a product of our capability, both physical and psychological, our opportunity, so our physical and social environment, and our motivation, which can be reflective, so conscious motivation, or automatic subconscious processes. So I'm going to sort of race through some of these findings, but we had 13 different themes identified in this study. And the themes related to capability and motivation were not really groundbreaking, but, still interesting. So I'll just quickly say, people needed to have the physical capacity, either with their upper limb function or live with someone to make it easier to use NIV. They also, talked about the importance of having sound knowledge and information about NIV, how it works and what are the potential benefits. And you can read the representative quotes while I talk. And it also really helped if you were one of those proactive people who, went out and sourced your own information. A number of people told us that they weren't told about NIV through their health professionals. They found out about it through their own research. And then those people too who are able to overcome problems and hurdles as they arise, because I will tell you soon about some of the hurdles that arise. Motivation, so this automatic motivation was, fairly powerful. So for some people with MND, this was NIV represented hope and optimism, and it was something that they could do, a treatment that they could do to help to make a difference. And so that was a real enabler to them choosing the therapy. But for others, it really brought up very negative emotions. And for some people, they felt like it was succumbing to the disease, or it was something, being offered NIV was signifying the end, and that could be a real barrier to accepting it. But I'll get on to opportunity, because this is where I guess a lot of the problems arose, and particularly in the subdomain of physical opportunity. So we've heard a lot today about the importance of a multidisciplinary clinic and some of the variation in the care that's provided by a multidisciplinary clinic. And the people we interviewed talked about this because they talk to each other. So they all know, as you can read by that quote there, what other people are getting and what they are not able to get based on where they live and the clinic that they have access to. Some people also talked about not being able to have NIV initiated in their home, or the respiratory assessments done in their own home, because for many people, hospital is a scary place, or it's very far away. And so for them, having an option to have some of these services come to their home would have been a big enabler. We've also heard about inequitable funding models for equipment, in particular NIV equipment. So, and every state has a different funding model. And then there's also obviously inequity around which of the, insurance schemes you have access to based on your age. And they cause big problems. Some of the enablers around physical opportunity, if people were provided early information and consistent information about NIV, it appeared that it made it a lot easier for them to choose the therapy and take up the therapy. And they also talked about this, appreciating that ongoing intention to revisit information, because, no doesn't necessarily mean no forever. People often say they don't want NIV, and they have a right to change their mind. And I think we talked a lot in our stakeholder advisory group about how clinicians need to keep revisiting that conversation in a way that doesn't feel like they're harassing the patient. And lots of stories too around late diagnoses. And, sometimes people have gone around and around in circles, misdiagnosed, or perhaps present late or progress rapidly, and their respiratory function's already deteriorating, and it's all too much to take on NIV at that point. Social opportunities. It was people in our study talked about having those positive relationships with their managing physician that were based on trust and mutual respect. And as you can read in this quote here, we had such trust in our physician that we said, well, when you think it's time, we'll go with that. And then also the other thing that came up that was incredibly important was peer connections. So those who were connected with their wider MND community through whatever groups or waiting rooms or whatever, they all learnt from each other, they talk to each other, and they really support and help each other. So that's the end of the study. I just want to spend a couple of moments going off script to show how this type of research can actually be used to make change, and how it is being used to make change. So this is the original group of the stakeholder advisor. We have grown since then. I like to call them the OGs, or the original gangsters. And while all this research was happening and we were collecting all of this information, as you heard Janet say, we had an opportunity to collectively put in a Fight MND care research grant. And so we were successful in a project that was funded last year, it's just started, around co-designing solutions that target these barriers. And so over the last 6 months, our research team at the Institute for Breathing and Sleep have been compiling all of the information that we have gathered from these studies over the last 2 years. So the survey data that I first spoke about, along with the qualitative interviews with people with MND and their carers, along with the clinician interviews, which I haven't presented today, but got some really rich and additional information about what's going on out there, to compile a list of 30 known barriers that is influencing, or not necessarily barriers, they could be enablers, but 30 known factors that are influencing the uptake of NIV in Australia. And 2 weeks ago, we put them all in jail for 2 days to scrutinise that list and discuss every single one of those barriers in detail, to hear each other's perspectives and to vote using a Delphi consensus methodology about which of those barriers are the most important. And a second question, which is which ones can we tackle feasibly in our 2-year project? And I've added, I don't think Phil and Nat are here anymore. I wanted to apologise to Nat for putting a photo up of her with her eyes closed, but I put them up deliberately. They were 2 of 6 people out of 19 who had lived experience on this group. We all had an equal voice in the room, but their voice was the most impactful. And I was told that by multiple health professionals and researchers in the room. So I just wanted to highlight what lived experience voices can do in research and say, watch this space, because we are formidable and we are about to make change, and you'll hear about it. Thanks.
Does anyone have a question for Marnie before she sits down?
Sorry, Marnie, it's kind of related. I guess depends on the answer. Is there any evidence that starting NIV as early as possible, perhaps before you've lost a lot of respiratory capacity, actually provides that a kind of almost protective benefit and maybe holds you much longer?
There's a couple of studies, but I don't think they're particularly conclusive. And there's some emerging studies that show that starting earlier rather than, at the point where most people start, which is, when they've got enough symptoms, may have additional improvement. But I don't think there's enough evidence to be probably recommending that yet. The discussion that we had in our group was that people should be able to start when they want to start. So a lot of people are being told, no, you can't start yet because your respiratory function isn't bad enough. And they're like, well, my respiratory function has declined and I want to start now, so why can't I? And so, so I think that evidence is emerging, but.
Marnie, what's your dream uptake rate? Like, how many Aussies with MND would you like to be using by that?
Thank you for bringing that up, Julie, because I guess what I didn't say is that we're not saying that everyone needs to take this up. What we're dreaming for is that 100% of people with MND can make a fully informed decision to take up this therapy with an excellent service. And for many people, though, they don't want this therapy, and that's completely fine. They can make that fully informed decision. I don't know, 80? I think the clinicians could probably say, we have definitely progressed since 20%. But until the MINDOS registry is more mature, we can't say for sure. But, that survey that I did of 224 people is definitely suggesting that maybe we're more around 30 to 35% now. And that's in line with international data as well, showing that it is increasing, the uptake is increasing around the world. I would say at least 60 up to 80%, uptake would be a great outcome, but not for everyone.
Thank you, Marnie.